Good morning and happy Valentine's Day. Thank you for joining PHCA for today's webinar, The Survey Process, What to Expect. I'm Wendy Johnson with the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and gain a better understanding of practical application tools to equip you so that you can continue to provide the highest level of quality care possible. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on the PHCA website by no later than close of business today. The webinar has been approved for 1 continuing education credit for nursing home administrators. Certificates will be emailed later today along with a link to a survey. Please complete this survey, and if you're participating in a group setting, please have each participant also complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. This webinar will be presented by Paula Sanders, Principal and Co-Chair of the firm's Healthcare Practice Group of Post and Schell. CMS claims it has combined the best of the 2 prior survey approaches, the QIS and the traditional survey, into the new and improved survey process that was rolled out across the country at the end of November 2017. The new survey protocol relies heavily on computer-based modules that all surveyors must use, with a special focus on interviews with residents, families, and staff. The good news for providers is that CMS has made most of the surveyor tools available, thus offering facilities an opportunity to understand and prepare for their surveys. This webinar will highlight key changes in the survey process and protocol strategies to achieve better survey outcomes. Your learning objectives for today's webinar include analyzing new survey protocol and identify CMS survey tools, improving mock survey processes to align with new survey expectations, and lastly, formulating strategies for responding to negative survey outcomes. I'll now turn the webinar over to Paula.
Thanks so much, Wendy, and good morning to everybody. It's always a pleasure to speak to the members of PHCA, and I just want to thank you and your staff for all the great work that you are doing, even if the government doesn't always give you credit for that. When I was asked to do the webinar, I thought I was just going to focus on the CMS aspects of the survey, but there have been some radical changes going on at the Pennsylvania Department of Health and their enforcement trends, and I want to just take a few minutes to alert you to what is current practice with the department with respect to issuing civil money penalties from the state surveys. What I want to start with is showing you how to read the state tags, because and we've talked about this before, those of you who've heard me speak before, the difference between the federal CMS civil money penalties that the department recommends to CMS about what they think you should be assessed versus the state sanctions for violating regulations under the state licensure law. And this is a screenshot of a statement of deficiencies. And if you look at the top left-hand corner, you'll see the F tag, right? This is an old survey. It's F157. And above that would be the whole description of the federal regulation, as well as what the department surveyors think this facility did wrong under 157. And then you see a scope and severity of D. And that scope and severity is a federal scope and severity. The Department of Health, under the licensure laws, they don't have scope and severity. It's non-existent. But what they do is list a number of different state violations. So if you look here, we have a facility that got a D, which is an isolated potential for harm, but it's not a G. There's no actual harm, and it's certainly not immediate jeopardy, and it's clearly an isolated incident that this facility got cited for. But under that, the Department of Health has cited this facility for 201.18B3, 201.18E1, 211.5GH, 211.12C, and 211.12D2. And you'll also notice that some of these, in fact, 4 of them, say previously cited. Some of them have been cited previously 3 times. It's also possible that the department will have cited these same regulations 6 or 7 times during this survey under different different federal FTAGs. So we ignore the fact now that we've got the federal FTAGs. There's probably, if this survey was an immediate jeopardy or actual harm, that there'd be a recommendation for a federal CMP. We're not going to talk about that. What we're going to talk about, though, is what the department is doing right now with how they are assessing state fines for state regulatory violations. Now, if you see here, you've got 201.18B3 and E1. They're both subsections under 201.18. Well, what does that mean? This facility, if it were to get cited right now, could be cited for each subparagraph at $500 a day. Same thing with 211.12 nursing services. We've got C and we've got D2. In some instances, the department will break it out, so you could get, for instance, 201.11.12, D1, D2, D3, D4, D5. Each subparagraph is $500 potentially. So I just want you to look at that, because the other thing that's missing from this statement of deficiencies is any explanation tying the alleged misconduct to the regulations. So 211, let's say 211.12 D1, if we just take that, says the facility has to have a director of nursing. But there might not be an allegation any place that the facility does not have a director of nursing. But I want you to, we'll come back to this slide in a minute. And I can't see all of you, but I'm assuming most of you remember about a year ago when Secretary Karen Murphy issued a memo saying she was going to start imposing per day civil money penalties. That was at the beginning of 2017. What we see here is what's been happening from 2014 to 2017. You can see in 2014 the average, the total state civil money penalties. This is not federal, and this is not the state portion of federal fines. These are Department of Health imposed licensure fines. They go from $79,250 in 2014 up to $412,200 in 2016. And 2016 is when we begin to see that increased enforcement from the department, which we've talked about on other webinars. But then look at 2017. In 2017, the department issued $2,019,750 in state fines. People have said to me, Paula, where's that money going? Well, the department is very limited in how they can use these fines. That money is restricted. It's not going into the general fund. So people who say, oh, well, this is how the governor's upping the general fund because we're behind. It doesn't go to state revenue. And it doesn't go to the department. They can't use this money to hire new staff or to buy equipment. This money is limited solely to 4 purposes under the Healthcare Facilities Act. One is to appoint temporary managers. A second reason the department can use these funds is to maintain the operations of a healthcare facility pending closure or correction of deficiencies. The third is to reimburse residents who've had their personal needs allowances stolen. And the fourth is to relocate residents in the event of a facility closure. So it's a very limited purpose. And at this point, if the department had collected all of the fines that were imposed, and I say if because many of these fines have been over the years and or are currently under appeal, but the total amount that the department has imposed since 2014 is $2,664,000. If you look at this next slide, we broke it down for you just so you could see how the CMPs have been assessed by quarter. And I think I must have a math error here because we don't add up to that same 2 million. But what you do see is in the fourth quarter of 2017, fines that are going up to about over $1 million. The total civil money penalties per year, this is just a different way of looking at it in terms of the number of sanctions. In 2016, there were 91. In 2017, there were 131 civil money penalties. Interestingly, though, when you look at when these sanctions have been issued and for what surveys, what this chart is showing you is that in 2016, we start to have a huge discrepancy between the number of days between the exit and the sanction. And in this case, the sanction is civil money penalties. This is not provisional licenses or anything else. And the reason is when you look at the Department of Health sanction list, which is available on their website, you will see that in 2017, most of the civil money penalties that were issued in 2017 were for surveys with an exit date in 2016. Only in December, actually in late November of 2017, did the department start issuing civil money penalties for surveys that ended in 2017. So there's a huge backlog of state survey that have the potential to have civil money penalties assessed against them, even in cases where facilities have already been assessed provisional licenses. So the department was holding a number of these surveys for a substantial amount of time. The maximum that we found, as of the end of 2017, there were 345 days between the exit date, which was in January 2017, and the civil money penalty, which came out in the end of December of 2017. The big change now, so they start doing these assessments in 2017. In December, there were 12 nursing home sanctions for 2017 surveys that totaled 1,200,000 $1,204,250, which is 288% more than all of the civil money penalties in 2016, and almost 2,000 times more than the total of civil money penalties in 2014. So how did that happen? I'm going to take you back to this sample state deficiencies. We see it's a D-level deficiency, and there are 4 that are repeats, right? The 18B3, 18E1, 12C, and 12D2. Because they are repeat deficiencies, even though these are under a D-level federal tag, the department will look at them and say, well, we've got repeat deficiencies. We're going to assess $500 a day for the repeats. So let's just focus on them. So we've got 4 repeats times $500 a day. And what they did for those 7 surveys that I mentioned just a few minutes ago that total over $1 million is they imposed a $500 per day civil money penalty from the date of the release of the 2567. So that would be from the date the facility gets the 2567 until the date the facility alleged compliance in the plan of correction. So if you take 4 times $500 a day, that's $2,000. If you said it was going to take you 45 days to come into compliance because you're doing your plan of correction and you figure, well, we've got to do new policies, we have to retrain staff, we want to make sure we have time to do auditing and monitoring so we can show we're back in compliance, which was, in the old day, a really wise thing. 45 days seemed like a normal plan of correction. The department, in this new approach, is going to charge you $500 a day for 45 days. That is a lot of money. If, on the other hand, you say, well, it's only going to take us 2 days to come back into compliance, so your date of allegation is 2 days, you're only going to pay $4,000 as opposed to 45 days times $2,000 a day. The one tag that is not repeat is likely to get fined under the new methodology at $250 per instance. So you add that $250 on to the multiplication of the per day for the date between the date you got the 2567 and the date you said you'd be back in compliance. And that is how the department seems to be assessing civil money penalties right now. I can tell you that there's been a huge uproar about the new methodology and its impact, and we're working very hard to get the department to reconsider this approach because it bears the outcome, the total of the civil money penalties has no bearing, no relationship to the scope and severity of the deficiencies. It's a mere mathematical calculation based on how long the facility alleges it's going to take to get into compliance and the number of deficiencies that the department has cited as repeats versus non-repeats. We have found over the years that facilities generally concentrate very heavily on looking at the federal tags. I would urge everyone to pay attention now, if you haven't already, to looking at the state tags, particularly those that have been cited before. Oftentimes the department is sending smoke signal messages, although they're not tied, as I mentioned, specifically to how the alleged violation relates to the regulations. And I'll give you an example of what I mean by that. There's a regulation that requires healthcare facility employees to wear ID badges. That's a state-only tag. If you violated that tag, there would be a state-only licensure deficiency that says you violated 28 PA code, I think it's 51.3 or 51.6. And then it would say, upon observation, the department saw that your CNA or employee 1 and 3 did not have their badges on, and this is a violation of this specific regulation. So you tie the violation to an observation that's tied directly to the regulation. These tags that you're seeing on your screen right now, there is no explanation from the department how whatever they are alleging as a violation of the federal regulation is also a violation of these more generic state tags. So that's the overview. I just wanted to draw to your attention the last civil money penalty that was issued by the state for a 2017 survey that's published on the department's website was issued January 3rd. There were no other civil penalties issued in January, which to me is an indication that the department is, in fact, rethinking how they're applying these penalties. So that's a diversion from the what you thought you were going to hear. I want to spend some time now talking about changes in the CMS survey process. Good news, Pennsylvania's going crazy, but the federal government is actually being more realistic, and they have actually revised their civil money penalty analytic tool and the policies in reaction, in large part, to very effective lobbying by the American Healthcare Association, various state affiliates, as well as Leading Age and their state affiliates. I think that the outcry was heard. There's been some backlash, obviously, from consumer groups and advocates, but I think this is a right decision because you can't just keep fining facilities and taking money away from the bedside. It's not serving any effective purpose other than driving folks out of the business. So what we see in the new revisions is using per instance civil money penalties in most cases for past noncompliance. However, there's still a possibility to get a per instance civil money penalty for noncompliance that existed before the survey and is ongoing, except for immediate jeopardy with actual harm, abuse with actual harm, or repeat tags at a scope and severity of G or higher, or scope and severity of H or higher. And that's one of the critical things, because remember, prior to this change, surveyors were coming in and finding a deficient practice that happened before your survey, and the civil money penalty was starting from the date that the surveyors found the first noncompliance and continuing all the way through until you come back into compliance. This now is saying it is the default is going to be a per instance as opposed to a per day. And that's had a significant impact on the size of the federal penalties. The other difference between how the federal government is imposing these civil money penalties and how the state is doing their per day is the CMS penalties, if you do get a per day, are running until the facility gets back into compliance. On the Department of Health side, they're only running from the date you got the deficiency statement until the date you said you were coming back in compliance. They're not continuing the way the federal CMPs would continue. And that's what ties it really to this mathematical formula. Also, under the federal side, the facilities with a good survey history may avoid a daily CMP, which means they could get a per instance CMP if they have a G or a J, J being immediate jeopardy, that involves a singular instance or a singular event. So that's also a good change. However, facility with repeats, patterns of G or above, or with 5 or more deficiencies will receive higher fines. You all know you can get a 35% reduction of your federal civil money penalty if you waive your right to appeal. The regional office, which in our case is CMS Region 3 in Philadelphia, cannot adjust the penalty more than 35% without central office's approval. Unlike, I just want to keep drawing comparisons between the federal side and the state side, there is no availability to get a reduction in the state fines if you waive your appeal rights. There's no built-in process. If you want to challenge your state fines, you absolutely have to file an appeal, and you also have to file what's called a request for supersedious. because under the state law, if you don't pay your fine, they're not going to issue your license. So you have to ask for a supersedious, which is a fancy way of requesting a stay of the collection of the civil penalty. On the federal side, if the fine is greater than $250,000, CMS central office must approve it. Also, on the federal side, if you want to get a hardship request, you can't wait until you get your total numbers. You've got to follow the deadlines very carefully. Your request for a hardship must be made within 15 days of the date that CMS tells you what your civil money penalty is. And that means you can't look at it down the road and say, oh, geez, I want a payment plan. Will they entertain a payment plan? The answer is no. If you don't file a hardship request, they're not going to give you that. Later look at you and say, okay, we're going to give you a payment plan. I would caution you that if you do have a high federal civil money penalty, the amount of information that CMS requires and from facilities has often led people to look for money elsewhere rather than file the hardship request, but that is out there. Also, on the federal side, you do have the right to file requests for informal dispute resolution. And you've got two bites at the apple on the federal side. One is within 10 days of the date of receipt of your 2567 or the statement of deficiencies. You get a second bite if CMS imposes a sanction against you, whether that be rescission of your nurse aid training program or the imposition of a federal CMP. You can file a second IDR at that point in time. You're filing that IDR is recommended. I'm suggesting to folks that they challenge whenever they can. I've had a few people think that they've had some minor retaliation, but by and large, the surveyors understand that the stakes are so high with these fines that it's pretty much normal now for people to be filing independent dispute resolutions. You cannot challenge, however, the state deficiencies. So that is pretty much where we are on the difference between the two sanction processes. You all know that CMS has issued the requirements of participation, or the ROPs. I don't want to spend a lot of time talking about the ROPs. CMS has released a new state operations manual for phases 1 and 2 that have all the new F-tags on them. The most recent version came out November 22nd, 2017. I actually have that saved to my desktop in electronic format. It's a great tool because you can go in, if you saved it electronically, and search various words like bed alarm or personal alarm. Also, if you save it that way, you can see the new information because it's color. All the new information is in red. Surveyors have been trained on the new survey process, which started effective November 28, 2017. CMS is continuing to update and revise new survey forms. And just a reminder that phase 3 implementation is coming down the road. That'll be November 28, 2019. As Wendy mentioned in the introduction, according to CMS, that was not my words, that was me quoting CMS, this new process combines the best of the traditional survey, which is what we've had in Pennsylvania, and the QIS surveys. All of the surveys are automated, and for those of you who've been through a new survey, you will have seen the surveyors coming in with laptops or tablets. The good news is that the surveyor's online training is available to the public. The bad news is this is all electronic, which means, it has the potential to make things more uniform, but it also drives the survey in a much different process. It's very much driven by the algorithms that CMS has set up. And a lot of the questions and the way things go, worse than what we used to say, when did you stop beating your wife? You know, the questions that the surveyors are being asked to ask people are very leading, to say the least. So we'll talk about that in a little bit. There are 3 parts to the new survey process. The initial pull process is 70% computer-driven off of the MDS. There's the sample selection process, and then the investigation, which involves observation, interviews, mandatory facility tasks, critical element pathways, and record review. Again, in response to very successful lobbying, CMS has imposed an 18-month moratorium on some of the phase 2 requirements, but that doesn't mean that the surveyors aren't looking at the new requirements. I think there was some confusion, and some people thought, oh, if this F tag is on the moratorium list, I don't have to worry about it. No, it just means that if the regulation is subject to the moratorium, you can't get fined a civil money penalty. You can't be given a denial of payment for new admissions or termination related to those specific F tags. Additionally, CMS is holding the 5-star ratings constant for 1 year during the moratorium. And people's got some mixed feelings about that, and that could be a whole nother webinar just on the 5-star process. These next 2 slides identify the F tags that are affected by the moratorium. If you do get a civil money penalty during this moratorium for these F tags, I would certainly consult with your counsel to determine how you're going to proceed, because these are the ones you should not be getting CMPs for under the federal system. So one of the mixed blessings of this new process is the mandatory survey task. On every survey, the department is coming in and they are looking at these specific tasks: dining, infection control, SNF beneficiary protection notification review, which is one that I still scratch my head over trying to figure out what exactly this is so important that they have to look at every single time, because I have not heard that this has been a problem, but they're looking at it. So an easy thing for you to look, I look at these, so these are my low-hanging fruit: resident council meetings, kitchen, medication administration, medication storage, sufficient and competent nurse staffing, and your QAA or QAPI programs. Mandatory, that means they've got to do it, and they've got their little laptops with them that are going to have links through all of these elements. And each one of these elements is set forth in what CMS is calling the critical element pathways. So you can go online and pull up all of the questions that the surveyors have on their laptop. And when I said there's an algorithm, if you're not looking at these algorithms, you're missing a huge opportunity, because this is what the surveyors are using. I happen to believe that the critical element pathways are going to be more significant in terms of survey enforcement than the state operation manual. And in fact, the surveyors are told, use the critical element pathways, and only if we don't address an issue should you be looking at the state operations manual. So these CEPs are going to be driving how your surveys are going. And you know, there's two pages of them. I've given you in the material a link to those critical element pathways. If you printed them out a while ago, go back, because CMS has revised a number of them in November, and I expect they'll continue to go back. So I would keep checking that link periodically. When you go into the little zip file and open it, you'll actually see the revision date. So you can go through and say, okay, we know they changed range of motion. They were positioning, mobility, and range of motion. That's one that they just changed in November. So you might want to pull that one up and take a look at it. So what I'm going to do for the rest of this is really talk about those areas I see vulnerability and things that we're starting to hear from folks across the state, actually from across the country. Note that in the CMS surveyor training, and this is a direct quote, a review of sufficient and competent nurse staffing will be conducted on every survey. This task is required to be investigated on every survey, since surveyors are always considering whether staffing issues can be linked to resident complaints or quality of life and care concerns. In addition, phase 2 of the new rule puts a lot of emphasis not only on sufficient numbers of staff, but also the competence of staff. And that, to me, is a sea change in how the surveyors are looking at staffing. And as they become more adept and more familiar with the critical element pathways, I think we're going to start seeing a lot more citations for staffing, both under the state regs as well as under the federal regulations. Quality issues trigger many questions about staffing. You know, not only were there sufficient numbers of staff and were they competent, but were you doing evaluations of your staff to show that they were competent? Was the issue the subject of QA or performance improvement? Interestingly, in Region 5, if the care plans are not individualized, people are getting automatic Fs as substandard quality of care. And that stems from the use of your electronic medical records that are generating care plans. So the substandard quality of care has been expanded. At the back of the slides, you'll get the 2-page toolkit from CMS. If you print out the slides in color when you download them, all of the ones in red have the potential now to be substandard quality of care. It's a much more expansive definition of substandard quality of care. Other issues, and we'll talk about them more as we go through this, is whether everyone on the team knows and understands the resident's care needs consistent with their roles, and whether the resident has a voice. I mean, those are the themes that you're going to see throughout the critical element pathways as you go through them, and we'll discuss them more in a few minutes. I know that you've heard a lot about the facility assessment. I'm not going to spend a lot of time here because I think that's a webinar in itself. But it's got to contain a description of your resident population and care required, staff competencies, including the outside contractors and volunteers consistent with their roles. It's got to include a description of your physical environment and equipment, ethnic, cultural, and religious considerations as well, type of services provided. And let me just pause here because I've gotten a couple calls recently about families wanting to use organic or vegan tube feedings, which are not medically supported. And I use this as an example. When you're looking at type of services that you're going to provide, one of the things you might want to consider is what kind of tube feedings you're going to allow. You know, if you decide this is something you really don't want to get involved in, your facility assessment is the first place to identify that. You know, you're saying, you know, we do not provide vegan tube feedings. We'll make it much easier if somebody wants then to insist that mom have vegan tube feeds, which are not medically indicated, to say, yes, that's not a service we provide. So you can be selective through the facility assessment as one of the first parts of the way you can try and restrict some of these more unusual things from coming in. Your assessment also needs to include contracts with third parties, information about your health information technology, and obviously your facility and community-based risk assessment for your emergency preparedness plan. The facility assessment is integrated throughout the regulations and shows up in terms of sufficient staff, specialized training, the neglect guidance, which talks about structures or the lack thereof that promote neglect. Again, your admission policy, limitations, and special characteristics. Think again to vegan or organic tube feeding as a good example of that. Your QAPI should be tailored to the services and population identified in the facility assessment. Compliance programs also reference your facility assessment. Compliance programs are a phase 3 in terms of CMS enforcement. They're obviously required or expected from the Department of Justice, but CMS has provided a facility assessment tool. It's not mandatory. A lot of folks have decided not to use it. There's another school of thought that says if CMS has provided it, it's probably what the surveyors are used to seeing in terms of a format, and it might be more easy for them to follow along with you. You do need to provide your facility assessment to the surveyors at the entrance conference, and you've got to make sure it's reviewed and updated annually, and any time a substantial change indicates the need for updating. Don't want to spend a lot of time talking about QAPI. I know that PHCA has provided a number of wonderful resources, as is the American Healthcare Association, but do consider the responsibilities of your governing body with respect to QAPI, and this slide here sort of lists the responsibilities for the governing body with respect to QAPI. I don't want to spend time going through that. Before we talk about these other areas of focus, I do want to just share for you some of the questions that are provided in the critical element pathways with respect to sufficient and competent nurse staffing. Because if you're not taking advantage of these resources, you should think again about whether you want to incorporate these into your mock survey process. Because remember, surveyors are going to walk in, and every survey they're looking at staffing, and the interview section of the CEP for sufficient staffing has them asking residents about staff competency throughout the survey. And those questions include, do you feel safe and comfortable when staff assist you? Do you think the nursing staff are experienced and knowledgeable when providing your care? If not, what concerns have you experienced? Do you recall a time when you didn't feel well? Did you tell a staff member? What happened? How did you get better or worse? Now, that's what they're asking the residents. If you're not having somebody going around asking the residents periodically these questions, shame on you. You've got it right in front of you. But still in that same line, and again to the notion of when did you last stop beating your wife, they're going to go around to your staff. And there are a number of questions that they're asking the staff, including, does your facility use agency staff? If so, how does that impact your daily activities? Now imagine that really disgruntled CNA getting asked this next question. Do you have any concerns about care when agency staff are used? Again, a great tool, knowing what it is that the department is asking your folks. You should be out there using these tools, staff meetings, getting this information, because it'll give you a handle on, and especially if there are concerns or you can show that there weren't concerns raised. It's showing your due diligence of what you're going on. We know we're looking very closely at admissions processes, including communicating your visitation policy up front. And I'll spend a little bit of time talking about that as well. Also, looking at the grievances and resident counsel, we're seeing a lot of complaints, a lot of citations coming out of the department's interviews with resident counsel. Again, use a critical element pathway, talk to your resident council folks, and get a good handle on what it is that they're saying, especially with respect to grievances and how you're responding to them. There's been a lot of talk about focusing on inappropriate discharges. You need to be reviewing your discharge forms and practices, looking at the notices that you're required to be given, updating all of that information to make sure that you're in compliance. There's been a bad press across the country about folks discharging. Again, going back to your admissions policy and your visitation policies, there may be ways to address some of these issues. Restraints. We are seeing folks getting cited for having position change alarms and side rail enablers. It's very important if you are using side rails as enablers, even those little quarter side rails or even the little circle rails, go into the State Operations Manual F604 and read them very carefully to make sure you're doing the assessments and have the justifications and are doing continual reassessments. Again, CMS is giving us the tools. We should be taking advantage of them. Another area where we are seeing a lot of problems arising is in the expansion of the definition of resident representatives. You need to understand the authority and limits on the authority of the guardians, the powers of attorney and resident representatives. And I've given you here the cite to F551 because you have an obligation to make a report to the state if you believe the resident representative is making decisions not in the best interest of the resident. And one of the pieces, I just want to pause there because a lot of times we're getting calls from facilities who've got disruptive families. You know, somebody's coming in either drunk or abusive to staff, and what can you do about it? You know, you need to address that in your visitation policy up front. Make sure it's clear what your expectations are so that you can take action. And if you do have to report them, make sure you have the citation to F551. The unfortunate thing is you can report to the AAA, you can report to the Ombudsman, you can report to the Department of Health. No one's going to do anything about it, with the exception of the police if the person is violent. But if there's an abuse situation and the alleged perpetrator was a visitor, go into the abuse critical element pathways and you'll see a number of questions that the surveyors are going to ask if the perpetrator was a visitor, including was there any indication of a prior history of abuse, aggression, or inappropriate behavior. So you do want to be careful on how you're documenting those incidents involving those disruptive visitors. The next area, and we'll sort of breeze through this one, is this new focus or heightened focus on abuse. We've got the OIG convinced that nursing homes are not reporting abuse and has been very critical of CMS. One of the new initiatives that's in the OIG work plan, which by the way now is updated monthly, not yearly, includes analyzing diagnoses from inpatient and outpatient facilities for conditions that may be the result of abuse or neglect. We're seeing a lot of cases where the hospitals are reporting alleged neglect or abuse directly to police departments. So I've listed here just for your reading, if you want to go back and forth to look at this focus that ties not only the fact that they think abuse is being unreported, but also that abuse is not being prosecuted by the state if appropriate. And we've talked before, Pennsylvania has a very active elder neglect prosecutorial team within the Medicaid Fraud Control Unit of the Attorney General's office. It's just another alert, again, you know, sort of the trickle down of what's bad for CMS is bad for us. CMS according to the OIG, has not imposed any sanctions under the Elder Justice Abuse Act reporting. And again, a recommendation, this is from August, that CMS should compare Medicare hospital emergency rooms with nursing home claims. So here is one of the critical tie-ups we've seen in the confusion between reporting, that the new requirements of participation incorporate the Elder Justice Act reporting requirements. I just want to go through the top piece here to draw this distinction. The Elder Justice Act requires reporting of any reasonable suspicion of a crime against a resident, and these are individual mandates. Anyone who has a reasonable suspicion has an obligation to report to the state survey agency and law enforcement if there's serious bodily injury immediately, but not later than 2 hours, and this is clock time, not anything else. This is real time. Once that suspicion is formed that a crime's been committed, if there's serious bodily injury, it has to be reported to the state agency and law enforcement no more than 2 hours, and no more than 24 hours if there's a reasonable suspicion of a crime and there's no serious bodily injury. In addition to that, on the right-hand side, you will see the standard abuse reporting that requires all alleged violations of abuse to be reported. That obligation is on the facility, not on individuals, and all alleged violations have to be reported in 2 hours if the alleged violation involves abuse, regardless of whether it's related to a crime. So any allegation of abuse has to be reported in 2 hours. Any allegation of neglect, exploitation, or mistreatment that results in serious injury also has to be reported within 2 hours. And then it's not something substantiated, that's the allegation, and 24 hours if the alleged violation does not involve abuse or it does not result in serious bodily injury. So I give you this slide, it's from CMS. Hang it up in your nursing stations. Very important to make sure we're complying with these timelines. Additionally, with respect to abuse, look at the critical element pathways. Every administrator, if there's an allegation of abuse, is going to be asked and interviewed very specific questions. If you're the administrator, I'd make sure you're familiar with what these questions are going to be. And likewise, if you are the quality assurance person responsible for QA and there is an abuse investigation, you too are going to be asked very specific questions, including how do you monitor reported allegations of abuse, and when did the QAA committee receive the results of the investigation for the allegation of abuse. So again, great tools from CMS. Kudos to them for letting us know what their thought processes are. Remember, I said just a few minutes ago that the OIG is concerned that CMS has not fined anybody for not reporting under the Elder Justice Act. I just wanted you to see what the penalties are. If you're an individual who should have reported and you didn't, you can be fined up to $200,000, possibly excluded from participation in the federal health care programs. And if your failure to report exacerbated the harm, you can be fined up to $300,000. Likewise, if you're the facility, you can be fined, but for retaliation. So we're looking at fines on the facility side as well. I use this in my training to make sure that everybody is aware of their obligation to report abuse. I think the fact that the OIG has yelled at CMS means we're going to start seeing penalties coming out now for failing to follow the Elder Justice reporting requirements. Also, to be prepared for media responses, because the Elder Justice Act requires you to report to law enforcement, and sometimes these reports show up on the police blotter, and you wind up with reporters questioning what's going on. So make sure you've got a media response program in place. The final area that I wanted to talk about very briefly is this new focus on volunteers. And if you go into the state operation manual and you type in the word volunteer, you'll come up with this information. But you'll see that the state operation manual is defining staff to include employees, the medical director, consultants, contractors, and volunteers, as well as caregivers who provide care and services to the residents on behalf of the facility, students in the NATSAP Nurse Aid Training Program, and students from affiliated academic institutions. That's in the F600 tag. If you look at the tag regarding screening, you've got to have policies now that address how pre-screening occurs for volunteers. Again, something that was not clear under the old state operations manual. The SOM, State Operations Manual, suggests that you should be requiring volunteers to be subject to the same scrutiny and maintain documentation that the screening has occurred. You've got to train them on the proper use of assistive devices and equipment. We're seeing a number of folks getting in trouble with the Department of Health because people are pushing folks in wheelchairs and forgetting to put the leg rest up, for example. Your compliance program has to set out consequences of violations of the regulations, including volunteers consistent with the volunteers' expected roles. They have to be educated about your compliance program. This is just more on the requirements for training and including evidence that your volunteers have been trained. So we can see, just highlighting a couple very specific areas from the state operations manual and the critical element pathways, gives us a sense for what we can be doing now. I would strongly urge you to review staffing competencies and your evaluation processes, making sure you've got documentation that everything is being done and being done timely and in accordance with your own policies and procedures. I would print the critical element pathways. I'd set up, if you haven't done it already, set up work groups. I'd assign people, this might be a great job for somebody who's on light duty. Ask them to go walk around the facility and interview residents on some of these critical element pathways, especially the ones that are on that mandatory list. If you're the administrator of the DON, don't stay in your office. Talk to your residents, talk to your families, talk to your staff, because that's what we know the surveyors are going to be doing. And, I don't always have a lot good to say about the government, but I have to take my hats off to them, because I really think we know that the surveyors have these pathways on their computer. We know what they're asking pretty much in the format that they're going to be asking, what the links are that take them to other critical element pathways, and we should be doing exactly what they're doing to be prepared. Forewarned is forearmed. I've given you in this material links to various documents, including the link to the sample facility assessment tool if you haven't used that, link to the critical element pathways, and at the end, again, are the expansions of substandard quality of care. And I just want, in closing, to draw your attention to the fact that the failure to talk to residents before roommate changes could result in a citation for substandard quality of care. Things to pay attention to. Some of these would just jump out at you as saying, well, this is really much different than it used to be. So take a look at those. And Wendy, I think I ran through my question time, but I'm happy to stay for a little bit if folks have questions, or if you want to send them to me and we can answer them and send them out electronically. But thank you all for listening so patiently.
Great. Thank you, Paula. I can tell by the number of folks who logged on today that this is a hot topic, so we appreciate all the information that you provided today. So at this time, we'll open up the question and answer portion. Please submit your questions using the box on the right hand of your screen. And we do have two questions already in, and I'll read those for you, Paula. The first one is there a limit on how far back DOH will go for repeat state deficiencies?
They typically look at 3 years, and you could see that if you look at the bottom of the 2567, that's usually how far back they go. They don't fine, under this new protocol, they're not fining for each time. So let's say, then I'm just going to go back to the beginning real fast because that'll be easier for me to explain it when I have that one slide up. They'll look at the fact that there were repeats. So, for instance, in that second listing for 201.18, you'll see the facility was previously cited 617.17, 517.17, and 629.16. They're not going to get 500 for each time that was a repeat. But what the department has been doing is saying, okay, we've cited you before for 201.18E1, so that's going into the repeat category. I hope that answers the question.
Great. All right, next question is screening for volunteers. Do we need to be doing TB testing and background screenings?
I could say there's an expectation on the background screening. On the TB screening, I am not 100% sure what the department's position is on that, but we can certainly follow up with the department, and someone can post an answer. Gail, is that Gail Weidman is in the room with me, and she said the PHCA will follow up on.
Yeah, I think it's required, but I wanted to.
Okay, Gail's initial. The folks here are thinking it is required, but we'll confirm that later. I don't want to give misinformation. That one I don't know. The background check I can tell you for sure. They're expecting those to be done, consistent again with their roles.
Great. I have another question. Do you need to have documentation when a resident gets a new roommate?
Documentation that you've explained to them. I would certainly include in a social service note that you've discussed it with the resident, and certainly when you're moving a resident from a room to room, there should be documentation of that as well. Remember, the intent of the new ROPs is very much person-centered, resident-centered, and they're looking at it from if you were in a hotel and somebody else was sharing your room, you would expect the hotel to talk to you about it. So it's that same concept, and it can't hurt to document that that's been done. Are there more questions?
That's all we have so far. So we'll just wrap it up here. If anyone has any questions, I'll be providing Paula's contact information in the follow-up email that will be sent out later. Again, don't forget to complete your survey. That will be emailed later today. And we'll have a recording of today's webinar made available on our website at phca.org. Please don't forget to complete the survey and check out our upcoming webinars. Next Wednesday, we have a webinar on mandatory abuse reporting, if you haven't already signed up for it. And we've got 2 webinars already scheduled for March and one scheduled for April, with another one that we're trying to get locked down. So we appreciate everyone's time today. Thanks again, and enjoy the rest of your day. Thank you.
Thanks.